Hi everyone, this is Mr. Neil Writers here, also known as the Wax Whisperer. This is a patient who attended today, but who had also previously attended back in March, I believe, early this year. And in fact, I uploaded the video of that procedure. It is video number 689, Complex Cholesteatoma Removal. I have put the link for you in the description. And at that particular appointment, I was focused more on this ear. This is the patient's left ear. And the patient attended with a really a blocked ear with dead keratin. At first, I wasn't sure if it was a cholesteatoma, and it ended up being a cholesteatoma that I removed. Now, with a cholesteatoma, if you watch that video 689, I do explain it in depth what it is. The cholesteatoma can grow inwards into the middle ear, but also outwards. And I removed the portion that was extending outwards. And the patient actually was seen by ENT. I did recommend the patient to see an ENT urgently if possible, and they went privately. And they had a CT scan, and it diagnosed a cholesteatoma, which wasn't visible to the naked eye in the left ear. And the patient underwent surgery. I will come back to that left ear in a moment, but this is the patient's right ear. Now, the right ear, the patient had previously had a cholesteatoma removed, potentially. The patient's not aware, many years ago. Now, when they came last time, this top part of the eardrum, and again, please do watch video 689, I do explain it in depth. This is the posterior superior quadrant of the eardrum, and the patient's had a retraction pocket here, which has caused a pocket to be created. And in that pocket, dead skin would shed and die and collect, and that skin would then get infected or form into a cholesteatoma. And it's eroded the bone at the top part of the ear canal, which has then exposed the middle ear bone. So you can actually see the hammer bone, you can see the neck of the hammer bone, the main head of the hammer bone, and also the incus, the body of the incus. Now, this was clean last time, this part of the patient's ear. So this is high risk now for cholesteatoma. Last time there was no skin in there, but you can see today there was a strand of skin that was just poking out, and I've gently now gone in with the fine end suction probe, and I'm gently just massaging and extracting this dead skin that's collecting in this pocket, this retraction pocket. If this isn't removed, it will lead to a cholesteatoma. And the patient, as I said, had surgery on their left ear for following a CT scan, which diagnosed a cholesteatoma that was naked to the eye. They also had a CT scan of this side, and although it was clear of skin at the time, the ENT surgeon quite rightly is worried that just about what we've done there today, that skin's going to gather in this pocket and lead to another cholesteatoma. So he's actually having this ear operated on in February in the new year. And I think what the surgeon's going to do is get a cartilage graft, and they're going to patch up that top part where it's exposed, the eroded bit. So I'm just going back in here. On the short process of the hammer bone, there's a bit of keratin. Now, this is not really that, I'm not too concerned, but I thought if it came off, I would peel it off, but it was a bit hard. You can see it just moved there. And the patient did find it slightly uncomfortable, so I left that. So the patient's going to have a cartilage graft. They're going to patch up that top part of the ear canal and eardrum where that bone's eroded. And what's caused it to erode is that the patient's had a retraction pocket, so the eardrum's got sucked in and it's compressed against the bone, and it's restricted the blood flow, which then causes the bone to necrotize, so kind of erode away. They also previously had a cholesteatoma there, so that got infected and it eroded the bones. There was two reasons there. And as a preventative measure, so although I've managed to get that skin out today, so that wasn't a cholesteatoma today, but if it wasn't removed, it would definitely have led to a cholesteatoma. That skin was trapped. It wasn't going anywhere. So the surgeon is going to operate. Now, just going back to the left ear, you can see that the ear canal is very sore. And that's because this patient actually just saw ENT yesterday for their follow-up. So they had surgery in March and they had their follow-up appointment. So you leave it 8 to 9 months to see how it's healed. And they there was a lot of skin, as the patient explained to me, there's a lot of skin that was on the canal wall, and the surgeon just peeled that skin away, and you can see it blisters, and that can normally happen. That's what happens with dead skin with peeling. You probably hear me say sometimes we leave skin if it's not ready to be peeled because it can cause the blistering. Because this patient has had surgery and they've had the mastoid bone enlarged slightly, The skin's more difficult to migrate, so as a preventative measure, again, quite rightly, the ENT surgeon has just removed that skin. There's a possibility that the patient's developed a bit of medial canal fibrosis following their surgery. So what the ENT's doctor's done, if you go back to my video, the original 689, there was a cholesteatoma formation on the posterior superior quadrant, so the top right-hand side of the ear canal upon viewing. And to prevent that part of the eardrum to get sucked in again and possibly lead to another cholesteatoma, so the surgeon removed the cholesteatoma and they put a cartilage graft there as well, so that skin can't retract inwards in that top part of the eardrum. You can probably see that on the right-hand side of the eardrum, there's a bit of cartilage there. But sometimes post-surgery, when patients have operations, they can develop what we call medial canal fibrosis, and that's a formation of connective fibrous tissue. And you can see that in the mid part of the ear canal on the roof. There's like, we also call it a false fundus. It's almost like a second eardrum. Now, the patient themselves weren't aware, but I've got a feeling that that's what the ENT surgeon removed yesterday, and that's why there's a lot of blistering there. And you can see the top part of that false fundus, the second, kind of the false eardrum. It's just on the roof of the ear canal. So the patient's going to have his surgery in February, and he's going to keep me updated. And he was very grateful for the referral I made and the advice I gave at his last appointment. Hope you enjoyed that follow-up, guys. I know some of you have been asking if I can follow up some patients. I've just remembered this patient. I've seen him before, and I thought, let me do a quick follow-up. Take care, guys. Bye.